right, we are on. Woohoo!
Yay!
Yay! All right, please introduce yourself. Tell us all about you.
Hi, I'm Elizabeth Lee, and I'm a plastic surgeon in Lafayette, California, which is in the San Francisco area. And I practice a full range of plastic surgery, have been in practice for 25 years. And I think Lisa and I are talking about the significance and the recovery of abdominoplasty or tummy tuck surgery.
Yes, yes.
And I'm excited.
So I'm excited too. So the way I found you, this was really fun. So I had someone reach out to me who had an abdominoplasty and just wanted a little bit of help bridging back to her fitness. And we worked together for about 2 months. It was lovely. And she had told me a little bit about you, and I was like, I need to interview this surgeon. Everything she told me was so awesome. I was like, yes. So thank you for taking the time and being here.
My pleasure.
And I know we talked on the phone a while back and had a really fun time with that. And you know that my goal is to empower women, educate them about the surgery, and in more of a specific subset, the athletic women feeling heard and really getting a clear picture on what the recovery entails, and then diving into actually understanding what's going on in the surgery. So,
right, we're on the same page.
Yes. Thank you, thank you, thank you. So if you could, I've been asking all the interviewees to just explain the abdominoplasty procedure to people that maybe aren't that familiar with it yet in your own words, and kind of talk about what you tell your patients or what you tell people in consults.
Okay. Consultation for me is one of the most important things a patient can do, because that is the chance for them to really learn in a good consultation about what is involved, what's being done, and to have all of their questions answered. It's also the time for them to really feel that they're comfortable with the surgeon they're interviewing, because this is a very significant relationship. And as I always tell my patients, on the flip side of this, if you decide that I'm the right surgeon for you, then I want you to stay off Google, because you're relying on me to provide care, and it's so hard to sort through all of the Google information that's out there. So if you find yourself wanting to go to Google, I want you to call me, because I can probably answer that question more carefully and even more easily for you. And I want you to get the information you need without being stressed and without trying to figure it out yourself. So I use this consultation as a chance to establish this kind of relationship, because this is a big operation and there's significant recovery. So when I talk to patients about tummy tuck, what I do is describe the way the abdomen stretches out during pregnancy and then can also splay out to the side. And so most women have the feeling that their stomachs are stretched out, they have extra skin. They usually call it fat, although it's often not fat. It's just all the thin layer of subcutaneous fat rolling over on itself as the skin hangs. And they feel like they're walking around looking 7 months pregnant, even though they're not. And often they don't understand that part of what has happened is not just that the skin has stretched out, but that the muscle layer can be stretched out too, so that you no longer have continuous muscle layer in your abdominal wall. So people have probably read about something called rectus diastasis. And that occurs because the two strip muscles that run up the center of your abdominal wall can be splayed apart from each other during the growth of pregnancy. And when that happens, the connective tissue between them stretches and has no elastic recoil. So after delivery, the muscles that have stretched out this way can shorten again, because that's what muscles do, but that fascia or connective tissue between the muscles, if it's stretched out, cannot rebound back. And so what you're left with is an abdominal wall where the rectus muscles are now bowed out to the side. And that sets up a whole dysfunction of the abdominal wall. And until those muscles are back in position abutting each other again, it's almost impossible to get your strength back and to be able to train properly. So I explain that to patients because it's very common that women will come in and they kind of feel bad being there. You know, I should just love my body the way it is. I'm a mother. I made these living creatures. I should, you know, I shouldn't be so vain to be needing to have like a flat tummy again. And they don't even realize that this is a functional issue too. It's not just about the hanging skin or about looking 7 months pregnant. So what we do with a tummy tuck is what I call a repair in 2 layers, because everybody knows where the incisions are for a, you know, low incision for an abdominoplasty. But the significance is that we do a repair of the rectus muscle diastasis, so that we actually do a permanent suture to pull those muscles back into the midline and anchor them there again. And that's the deep layer of the repair, and that's the functional part. And then we're able to kind of take that extra apron of skin and fat that's hanging off and take that out so that you then don't have all that extra stretched out skin. And it's important to understand, I think, what's being done to your body when you have surgery.
Yeah. So 2 really cool things. One is, I'm just so glad you're saying that, because I talked to a lot of women and I asked them, oh, how is your repair done? And a lot of them don't really know. And we'll get into that, you know, the way you like to repair, kind of sutures, all that stuff in just a minute. And the other part to that is the shame of getting the surgery. And, you know, like I told you a little bit about my story, I did get really strong with a really large diastasis, but I knew I still needed it repaired. Right. And I was okay with all of that by the time my journey had come full circle with this, right? But a lot of women don't have the support and all of that, and they can't figure out why they can't heal with this diastasis program that says they should be able to, you know, all of these crazy marketing things. And it's a really kind of messed up place to be. There's some women that have babies that don't, like, they rehab, they get strong, and they're fine. Their tissues are okay, and other people's just are not. Like there's not always a rhyme or reason to it.
We all have different consistency.
Right.
All our tissues are different, and you just have to operate for a year to be able to tell that some people are made like this and other people are made like that, and that's reflected in how our bodies recover from pregnancy.
Right. And that's not really under all of our controls. We can do whatever, but you can't control that part.
Right. And I, you know, often feel we're doing a disservice to women when we say to them, oh, you know, all you need to do to repair your rectus diastasis is just to do, you know, a rectus diastasis repair program. And yes, you can strengthen your rectus, but you are never going to, and you can learn to actively bring it back into the midline, but you are never going to have it stay there, what we call passively, which means that you're not having to activate the muscle and concentrate on it until it's anchored back there in the midline. And it's even worse than that, in my opinion, because if you have a rectus diastasis, it's not only the rectus muscles that are not working properly, but the other major core muscles, which we consider to be the internal, external oblique, and the transversus abdominis, all start in the back. They wrap around the waist, and they really end in the outside border of the rectus muscle. So muscles are designed to be at their strongest at a particular length of stretch. So I always say to patients, think about trying to get yourself out of the swimming pool. You will automatically put your hands about shoulder distance apart, because that is that's the distance at which all the muscles of your shoulder girdle and your arms and your chest are engaged to be strongest to actually push yourself out. If you put your hands all the way out to the side, it's much harder to do that because those muscles are not at the proper length of stretch. So when you think about having all these large abdominal core muscles ending in the outside border of the rectus, and if the rectus were in proper position, they would be held to this length. And if the rectus is lying out there an inch to the side, then none of those muscles are being held to length either. And lastly, when the rectus is in the wrong position, our brain often doesn't remember how to use it properly to coordinate. So if it's not firing instantaneously before the more side muscles fire, then the action of the side muscles are going to be to make that diastasis worse. So you can be doing crunches and core work and all the rest of that, and if you are working against a rectus that's not firing at the proper time, you're actually making the whole situation worse.
I'm so glad you brought that up, because that's such an important thing. Like in my own journey, like people saw me at, right before surgery, 2.5 months with a large diastasis, doing sit-ups and muscle ups and all these things. But I had figured out how to do it. You know what I mean? And it took me a while. Like, it's not like I just stepped up out of birth and, because it would have possibly made things worse and things like that.
Right. And it makes it worse for a lot of people.
So my first pregnancy, I didn't really understand that stuff. And I had a really hard time back until I got some better physical therapy and information and how to load and be strong and all that stuff. And then the second time I did it too, but like, I also knew like those tissues weren't going to heal, and I would, surgery was going to be at this point. Right. And, I think that a lot of surgeons, obviously they work with the muscles, right? But they're not talking in athletic terms to women. And so for me, it was very panicky, because I was trying to find someone to understand what I wanted to do and trying to explain CrossFit and all these heavy weights. And the first 2 surgeons I saw were very nice. They were lovely, but like, they didn't get it. And so it made me nervous. Like, and maybe they would have repaired me the same way as my surgeon did. I don't know. But like, I couldn't go under the knife fully knocked out knowing someone didn't know what my overall goals were.
Right.
Because who knows what you find another hernia, or you find this, that, or whatever.
Right.
So cool. All right. So let's talk about sutures. We've talked about that a little bit. We'll get into recovery in a second. But so you said you use, there's permanent versus dissolvable, there's versus interrupted, there's how many layers, are you using mesh? So tell us a little bit about what you like to do. I know everybody's maybe a little bit individual in that way. But.
So I use I'm going to talk about what I use for the plication, for the rectus, the rectus diastasis repair, and that's different than what I use for the skin.
Right.
So what I do with the rectus plication repair is I put in a permanent running suture.
Okay.
And I do that repair in 2 layers. And the suture that I use is a barbed suture.
Okay.
So the brand that I use at the facility where I work is called Quill. Okay. I don't think there are other ones, but this is just the one. The significance of it, though, is that the suture is not smooth all along the edge. Because what happens when you put in a suture and it goes back and forth like this is that everywhere that if it's a smooth suture, every switchback is where the maximum amount of tension is on that repair, because the portion of the suture that runs perpendicular to what you're fixing has no tension in it at all. Okay. So when you put in a suture that just goes back and forth like this, then those ends have all the tension and they can stretch out. What the Quill suture does is, because it has these tiny little barbs in it, the tension of the repair is distributed all the way along the length of the suture, because even though the suture is running this way, the little barbs are holding the tissue. Okay. So when we put that Quill in, we use much less suture material because we don't have to tie frequently, because we're doing a running suture, and because it's got those micro barbs, even if the suture were to break, it's not going to all unravel the way a smooth suture will. So I do a 2-layer repair. It's a stitch, a single stitch up and down above the belly button, and another one up and down below the belly button. And that's just there, and that holds you. Because if you put in, my belief is that if you put in just temporary sutures or dissolvable sutures in the repair, what can end up happening is that you haven't done anything that makes those edges heal together, right? You haven't cut them, you haven't created an injury. So you can expect that unless you're a patient who makes a lot of inflammation as you heal, that once that the strength of the suture is gone, that repair can open up again.
Okay, so because you're just relying on the scar tissue, correct?
Yes,